hearing from Dr. Bob Wachter on information transparency and health IT safety, along with 2 reactors. And if we can go to the next slide, please. First, a few housekeeping rules. If you have any technical questions, trouble with the webinar, type your question into the questions panel at the right, and we'll try to help. And if you have questions for the presenters, also use the question panel at the lower right. All telephone lines are muted. Because of the number of attendees, as I said, just use the question panel for questions. And if you would like to access closed captioning for today's session, that's available at http://www.captionedtext.com, and the event number is 2700030. Question and answer will take place at the conclusion of each presentation. And if you would like to access the slides and a copy of a recording of the session, those will be posted at www.healthitsafety.org. If you have any general questions about the webinar series, you can email healthitsafety@rti.org. Next slide, please. Would like to introduce the Health IT Safety webinar series itself. It's a series of 10 webinars that are focused on health IT and safety issues, and they're occurring monthly through September 2015. This is the 9th of the series. These webinars are funded by the Office of the National Coordinator for Health IT. They're being conducted by RTI International, which is a nonprofit research organization, and this is part of a year-long project to develop a roadmap for a Health IT Safety Center for the ONC under contract. Additional information about the project is available at www.healthitsafety.org. And the views of the speakers are their own and do not represent the views of RTI or the ONC. Next slide, please. Today's presentations are from Dr. Robert Wachter, who's professor and interim chair of the Department of Medicine at UCSF, with reactions from Beth Daly-Ullum, who is a patient advocate and former board member from Theta Care and Children's Hospital of Wisconsin, and Marshall Allen, who's a reporter for ProPublica, and I'll introduce them separately. This is Jonathan Wald. I'm going to serve as moderator, and I serve as a director of patient-centered technologies at RTI. Next slide, please. This is a little bit of background for me, and I really just wanted to add that I serve in roles on a variety of different projects, and for 10 years led patient portal design, deployment, and research at Partners Healthcare in Boston. Also served as a fellow in the American College of Medical Informatics and on the executive committee of the Society for Participatory Medicine. Next slide, please. So now to start our presentation, today's presenter, Dr. Robert Wachter, is professor and interim chair of the Department of Medicine at UCSF. He also directs the Division of Hospital Medicine, has written 250 articles and 6 books, has been at the very start of the hospitalist movement, and is a past president of the Society for Hospital Medicine and past chair of the American Board of Internal Medicine. In the safety and quality areas, he edits the U.S. government's 2 leading websites on safety, received an award in 2004, the John Eisenberg Award, the nation's top honor in patient safety, has been named in multiple years for Modern Healthcare Magazine's list of influential physician executives in the U.S., and recently released a book called The Digital Doctor, Hope, Hype, and Harm at the Dawn of Medicine's Computer Age, which has received stellar reviews and has been a New York Times Science bestseller. Dr. Wachter is going to present first on the implications of transparency on health IT, data at the level of individual patients. And then we'll have a reactor, Beth Daly-Ullum, and Q&A. Then we'll have a second presentation, also by Dr. Wachter, the implications of transparency on health IT, focused on data at the level of providers and healthcare delivery organizations. And then we'll have a reactor with Marshall Allen. So with that, let's go to the next slide and take it away.
Thank you, John. It's a pleasure to be a part of this presentation, and thank you to RTI, and thanks to ONC for supporting this. This is a large charge and a large topic, but an exciting one, and I think an incredibly timely one. And I've decided to kind of divide this into two buckets. One is focusing on the individual patient, and the second is looking at it from higher up in terms of health policy and the implications for healthcare delivery systems and policy. So here's my kind of roadmap for what I'd like to do in the next half hour, 40 minutes, is talk briefly about where we are in digital medicine. And part of the reason I spent the last couple of years researching and writing a book about this was it strikes me that we have now entered a new world, and we need to understand the implications of that. I'm going to talk briefly also about the case for transparency, and then really kind of talk about the Venn diagram of those two issues, that the case for transparency has grown and technology enables transparency in all sorts of new ways. And as I said, I'll then drill into this in two different ways, looking at the level of the patient, with then Beth commenting on that, and we'll have a Q&A, and then talking about it at the level of the system, both the healthcare delivery systems and the healthcare system more generally, and Marshall Allen will chime in at that point. So hopefully it will be exciting, engaging, and we'll all learn quite a bit. So let's start here with kind of the big picture context. To me, we are in a healthcare system that is undergoing two major transformational trends, two forces, and you could probably think of others, but to me these are the biggies. And one of them is tremendous pressure to deliver high-value care, pressure that really did not exist in any meaningful way on doctors or other clinicians or healthcare systems until, think about it, over the last 10 or 12 years. I think that is a humongous pressure. The second force is the digitization of the U.S. healthcare system, which is a relatively recent phenomenon. It's not that computers are new in healthcare or technology is new in healthcare, but the wholesale transformation of healthcare from a primarily analog to a primarily digital industry is something that has really only happened over the last 5 years. I would say today, when you think about these two trends, you would come down on the side of the high value circle being the dominant circle. That's really the sea change in healthcare. It's only going to grow as the payment system begins to move from volume to value. I am guessing that 15 years from now, we will believe that the other circle, the digitization of the U.S. healthcare system, will have been the more transformative force. Not today, but I think over time, its ability to enable all sorts of new things happening and new entrants into the healthcare field and new abilities for patients to manage themselves will turn out to be the bigger deal in terms of the kind of upending of the status quo in healthcare. It's harder to imagine what that will look like as you think about technology transforming the rest of our lives. And so I think we tend to focus on the other one, which is a little bit more accessible to us. But I'm guessing 15 to 20 years from now, that's going to be, the digitization is going to be the bigger deal. Well, let me talk just briefly about the value piece, and you know, it's what we're all struggling with today. If you're in the healthcare delivery world, you're feeling these new pressures. And I was talking a couple of years ago to the medical students at my institution at UCSF, and they're incredibly bright and engaged and optimistic. And I don't know, I probably had an argument with my kid or something. I kind of felt like saying something that would really make them concerned about the world they were getting into and recognize how big a deal the changes were. And I said to them in a voice sort of brimming with gravitas, I said, you folks are entering a profession that is wholly different than the one I entered 30, 35 years ago, because you will be under relentless, unremitting pressure to figure out how to deliver the highest quality, safest, most satisfying care at the lowest possible cost. I was trying to shake him up. And one of the students raised his hand and he said to me, what exactly were you people trying to do? And I thought that was just the most brilliant question, because on the days that we all have where we're struggling under the weight of these new pressures, what's important for me to realize, and I think for all of us to realize, is that what is odd is not that we're being put under these pressures now to deliver high-value care. What's odd is that it's new. What's odd is that this was not the way that healthcare was always organized, always incented, paid for, that it didn't drive our transparency program. But to me, and to those of us who've been at this for a while, it's a huge change. For new people entering the field, it's completely natural. Of course, we're under pressure to deliver the highest quality, safest, most satisfying care at the lowest possible cost. What else would you be trying to do? And I think that's the environment that we find ourselves in today. Now, where does transparency fit into this? Well, I think it's been one of the great surprises, and in some ways a pleasant surprise, that the pressure to figure out how to deliver higher value care has led to a massive growth in understanding of the need for transparency, the moral correctness of transparency, and the pragmatic efficacy of transparency as a tool to drive us toward higher value. I happen to participate and co-chair a group for the National Patient Safety Foundation's Lucian Leap Institute that put out this report earlier this year. It's called Shining a Light, Safer Healthcare Through Transparency. Beth was on that committee, and how we first met. It was a wonderful, diverse group of people that really thought very hard about the role of transparency. I commend this report to you. And the next couple of slides are going to quote from it. We came up with a definition for transparency: the free, uninhibited flow of information that is open to the scrutiny of others. We came to believe that it's essential for establishing trust, accountability, and ethical behavior. It doesn't fix anything by itself, but it's a necessary first step or precondition to improvement. And one of the things I think we came to understand is that it's a relatively inexpensive and effective tool. And we'll get back to this in the second section when we talk a little bit more about transparency versus payment changes as two ways of trying to drive the system toward improvement. But just the cliff notes is that we have found that just putting data out there seems to drive levels of improvement that often are surprising and not as difficult and fraught as many people worry about as they get into this world of transparency. In the Lucian Leap report, we thought of transparency in 4 different buckets, and you see them here, and they include between clinicians and patients, among clinicians, among healthcare organizations, and then with the public. And the report goes into these in all great detail. Here in this particular presentation, we're really going to be focusing in the first section on the top one, between clinicians and patients, and the second one in the section with Marshall, transparency vis-a-vis the public. Those are the 2 main buckets that we'll focus on here. But just to point out, there are other domains of transparency that are important, and one of the themes of our NPSF report was the interrelationships between these different buckets. So for example, you might say, of course, all data around errors or problematic performance within an organization should be shared with the public because the public has a right to know. But then you recognize that if you do that, you may inhibit the free flow of information within the organization that you need to improve. And so there's a tension there between these buckets that need to be reconciled. What are the barriers to transparency? You could probably come up with more of them on your own. This, again, is from the Lucian Leap report. Here were 4 that we thought were dominant ones: fears about conflict, disclosure, and potential negative effects on reputation and finances. And you might say some of those fears are appropriate if you are performing poorly, but people fear that there will be disproportionate or inappropriate negative effects. A lack of a pervasive safety culture and the leadership commitment needed to create it. And we certainly saw and highlighted in the report examples of organizations that have embraced transparency in a full-throated way. And what's really striking about those organizations is A, how unusual they are, and B, the importance of leadership and the leaders just believing this is both morally the right thing to do, and it will help drive the organization to do and be better. And the examples show that it can be done, but certainly they are the exceptions, they are not the rules. Stakeholders often have a strong interest in maintaining the status quo, which may be an obstacle to transparency. And there's a lack of reliable data and standards for reporting and assessing behavior. And this will come up, I'm sure, in our discussion with Marshall, who has been learning about the backlash that sometimes organizations get as they begin to become more transparent, because the data are never perfect. And one of the things we have to decide as a system is, are we going to wait for perfect data in order to be transparent? And the answer is, if you do, you probably never will be transparent. And so there's a tremendous tension there that needs to be reconciled. I'm now just going to shift a little bit toward the role of IT, which is really what I was asked to speak about here, and I haven't really said anything about IT so far, but here's how I see it in this particular domain, that there's always going to be a tug of war between the forces that promote and the forces that inhibit transparency, and I've just given you 4 pretty big reasons why the forces inhibiting transparency are pretty powerful. And to me, the issue here is that IT tips the balance massively towards transparency. And if you think about this tug of war, all of a sudden you have that big truck on the other end. I think IT is that truck. I think IT changed the dynamic of this equation so that some of the objections against transparency are now overcome because of the ease with which you are able to be transparent, facilitated by data collection and data sharing via IT. In my thinking and reading about people's discussions of IT, I think this has been an underemphasized benefit or harm of IT, depending on how you feel about transparency. I'm generally in favor of it, so I see it as a major, in some ways, partly anticipated consequence of information technology. But there is no question that as we see healthcare going digital over the last few years, we see a massive increase in transparency facilitated by IT, one that will only accelerate, I believe, over the coming years. Now, why do I say that healthcare has just become a digital industry? This is what led me to decide to devote some time to writing about this. Up until 2010 or so, we were an analog industry. Doesn't mean that some places didn't have computers or computerized order entry or barcoding, and we certainly had a lot of technology in the building. People always came up to me and said, why are you in healthcare such Luddites? And I said, Luddites, you crazy? Come to our radiology department. We love technology, but we love it when we can stick it in a silo of the building, not have it change the nature of our work in any meaningful way, and we can bill for it. We're pretty good at technology. But we certainly resisted the ubiquitous use of technology in terms of electronic health records or computerized order entry until about 4 or 5 years ago. And of course, the transformational moment here that was when the economy imploded in 2008, the Congress passed the HITECH Act, which basically led to $30 billion being given to doctors' offices and hospitals to put in electronic health records that met certain standards called meaningful use. It led to, obviously, a growth in the authority of the Office of the National Coordinator. And although there's been some debate in the literature recently about this, to my mind, it's hard to explain this curve based on the natural, based on nature and organic growth. I think you see the incentive start and a massive uptick in the rate of computerization of American doctors' offices and hospitals. This curve is about hospital adoption. What I think it says is it's not hyperbole to say up until 5 years ago, American healthcare was primarily an analog business. Now it is primarily a digital business, and that is a very, very big deal. Now, part of what got me to want to think and write about this is, as everybody knows, this has not gone as smoothly as we would have liked in all sorts of ways. This is one of sort of the iconic moments that I found. This is an ad for a hospital in Arizona that came out last year, located in Levine. It's a suburb of Phoenix. It's a boutique general hospital. That sounds pretty cool. Now, remember, they're looking for an ER doctor. So what are the services they have? They have an emergency room, which is great if you're looking for an ER doctor. You want that. They have a radiology suite with all the latest toys. They have 2 state-of-the-art ORs, they have outpatient surgery, 16 inpatient rooms. But the only part of this advertisement that was in bold, it was clearly what they saw as their big selling point, was they have no electronic medical record. So in 2014, a modern hospital saw fit to advertise for a doctor saying you can use pen and paper. This is just my way of, in shorthand, telling you that something you already know, which is this has not gone perfectly well. There have been fits and starts, and there are a lot of unhappy clinicians out there as they're trying to use these electronic tools and finding them somewhat wanting. That does not mean that we pull out the wires and bring back the 3-ring binders and the clipboards. I believe deeply that we have to do this, but we also have to understand that some of this dissatisfaction is quite appropriate because the tools are not very good and we've not reimagined the work in the way that we need to. What I've come to learn in thinking about this was we treated computerization as a technical problem. It's in many ways the mother of all adaptive problems, as Ron Heifetz, who talks about this, writes. Adaptive problems are those that require people themselves to change. In adaptive problems, the people are the problem and the people are the solution, and leadership is about mobilizing and engaging them with the problem rather than trying to anesthetize them so you can go off and solve it on your own. Now, I bring this up because I think that the degree to which IT facilitates transparency is in that class of adaptive problems. You know, that's not something that was in the user's manual when you opened up the box from your Epic or your Cerner system and said, oh, here we have technology. Cool, it's going to enable transparency. But it does, and it's one of many adaptive problems that healthcare organizations and clinicians need to understand and deal with and hopefully use to everyone's benefit. So let's switch for the last few minutes here to this particular issue of transparency at the level of patients and clinician-patient relationships. Let's start with the good. Everybody, at least you never hear somebody sort of say out loud that they're not in favor of patient engagement on moral and ethical grounds. Patients have a right to see their record, have a right to be engaged participants and drive their own care in all sorts of ways. Difficult to make a counter argument on moral or ethical grounds there. Many patients want to and in fact can be active participants in their health and healthcare, and an engaged, informed consumer is at the heart of why our economy works relatively well and how we produce high-value products. And I have here on the bottom a few examples of industries that have done well because they have produced products that people, when they make consumer decisions, decide. You know, when I go to Starbucks in the morning, I decide whether my tall mocha is worth $3.65. If it is, I buy it. If it's not, I don't. And I'm making a decision based on value. And if I decide I don't want to go there, and a lot of other people make that same decision, Starbucks goes out of business. So I think part of the subtext here is that transparency, providing people information so that they can make more informed choices about their care, will drive ultimately a better outcome and better output from the healthcare industry, as it seems to do in the rest of our business environment. And I think as you spool this out, and I wrote about this some in the book, as you spool this out, you can paint a picture that's pretty magical and pretty wonderful. And although I spent some of the time talking about the hype and trying to dial it down a little bit, you can think about a future where transparency and IT-enabled transparency is giving patients the information they need to make informed choices. And those are not only leading to better choices by patients, but also improvement on the part of healthcare delivery systems so that they become the victors in those choices. You also see a world where IT enabling will allow much care that currently is delivered by enterprises like doctors' offices or hospitals becoming self-care aided by computerized decision support. And that's people using data from surveys, labs, sensors, genes, social media, and more. Eventually, we'll be able to separate wheat from chaff with big data and use it for the purposes that it's being hyped for now. And both IT and personal integrators will help guide us. By personal integrators, I mean that people talk about how the sensor is going to throw off your vital signs and the doctor will be seeing that your heart rate spiked a little bit and call you. That's crazy. I mean, the workflow won't work there. But we are seeing the development of coaches and other middle people in this system who kind of look at your essentially air traffic controllers, look at the data from all of patients and help them, guide them toward healthier behavior. And I think you can think of systems that will suggest appropriate behavior and even nudge us toward it. And so you can imagine in a world with the Internet of Things that not only is it, the patient with heart failure, not only is it giving you information that you've gained a few pounds and maybe you want to cut down on your salt intake, but maybe even it can lock your salt shaker because it's got, it's Internet enabled. So it's a pretty exciting world. And we're also seeing a world in which patients are beginning to use the internet as a diagnostic tool. 59% of US adults have looked online for health information in the last year. 35% say they've used the internet to make a diagnosis. 53% of these diagnoses, these patients making these diagnoses, talk with a clinician about what they found online. That means half the people are not. And 41% of these diagnosers had their condition confirmed by a clinician. That leaves a pretty good percentage where the clinician said that's not true. So let's sort of end with a few observations of issues here where I think there really will be massive change and potentially challenges, or at least potential problems to work through. I hope some of you are Seinfeld fans. Obviously you recognize this is Elaine, a famous Seinfeld episode where she goes to see the doctor and she peeks at her paper chart when the doctor is out of the room, and she sees that in a prior visit someone has labeled her as being, quote, difficult, and she obsesses for the rest of this visit about that moniker that she's been called difficult, and the doctor, to humor her, erases the chart in her presence, and then she says, but doctor, it was written in pen, you fake erased. And so there have been people, clinicians largely, who have worried deeply that although it sounds good to give patients full access to their medical record, that we're going to have this epidemic of fake erasing as patients look at their chart and don't like what they see. Now that said, there have been studies led by Tom Delbanco and Jan Walker at Beth Israel Deaconess looking at open notes, patients having full access to their notes. And here's an area of transparency that is markedly enabled by information technology. Why do I say that? Well, patients have had a right to see their charts since 1996, but try to march into a paper hospital and go to medical record and say, I want my chart. And the answer is, we'll get it to you in 3 weeks, and it'll cost you 75 cents a page for us to photocopy the 700 pages. In other words, we don't really want to give you your chart. Once the chart is an electronic health record, what stands between a patient and their chart is a password. And to me, this then becomes an inexorable force. Again, this is sort of the change in the tug of war. You know, the tug of war between patients wanting to see their record and patients having access to their record. Up until now, the status quo has won because getting a patient a paper copy of their record is so logistically difficult. But once it's electronic, it's not difficult at all. All you have to do is enable the password access. And so Tom and Jan and others have shown that open notes actually works quite well, and most of the fears that clinicians have had, that patients aren't going to understand or going to react badly, have generally not materialized. And even the clinicians who worried about this in the beginning generally feel that it works out okay. Not seamlessly, it is not without challenges as patients see things that they question, and providers sometimes no longer are writing honestly in the chart about their differential diagnosis because they're worried that patients will not understand that the patient who comes in with a certain set of complaints, and if on my note I write, you know, I think this is X, but I'm worried that it could be HIV or cancer, I may no longer write that in my record. But this is an area where I think is one example of how IT enables transparency in a way that, that I think makes it inevitable. So what are some of the problems? Just quickly moving toward the end here. Here are just 3 of them, and I think you can come up with others, but here are 3 big ones that I think are worth thinking about. The iPatient, the limits of patient self-diagnosis, and the limits of patient self-treatment. And let me just highlight what I mean by these 3. The term the iPatient was coined by Abraham Verghese, a professor at Stanford and a wonderful author, in a New England Journal article in 2008. And let me just read this to you because I think it's both profound and also a beautiful piece of writing. Abraham wrote, "The patient is still at the center, but more as an icon for another entity clothed in binary garments, the eye patient. Often ER personnel have scanned, tested, and diagnosed so that interns meet a fully formed eye patient long before they meet the real patient. The eye patient's blood counts and emanations are tracked and trended like a Dow Jones index, and pop-up flags remind caregivers to feed or bleed. Eye patients are discussed in the bunker, the team's conference room, while the real patients keep the beds warm and ensure that the folders bearing their names stay alive on the computer." Just a beautiful piece of writing and profoundly true. And as we talk about the safety concerns around IT and transparency and data access, this is one that fits in there somewhere. It's maybe slightly orthogonal, but the idea that clinicians are increasingly taking care of the digital representation of the patient rather than the person, him or herself, is a huge issue, and one that I think we have to reconcile in the name of patient safety and patient-centeredness. This is my son Benji. This is actually him narrating the audiobook of my book. I'm very proud that he did that. He did a wonderful job. He's a delightful, healthy 22-year-old who called me a couple months ago and told me that, Dad, I have diabetes and glaucoma. I said, Benj, why do you think that? And he told me the symptoms he was having, and he said, I looked it up on WebMD. And I said, Benji, please don't do that. And so here is, I think, a real danger of patient self-diagnosis. There's a lot of craziness on the internet. There's a lot of things that are plain wrong. This was one that wasn't plain wrong. It's just that the nuance between connecting his symptoms and what the internet says those symptoms might be is just wrong, and does take, at least in today's technology, does take a experienced, well-trained intermediary, namely a doctor, or doesn't have to be a doctor, but someone who knows stuff, to connect those dots in a way that doesn't come out with a scary and incorrect answer. And I don't think we've thought that through. I think the magic of patients being able to self-diagnose, if we get it right, is wonderful. If we get it wrong, creates a brand new safety hazard that I don't think we have thought our way through yet. Finally, and I'll end with this, this is really the dangers of patient self-treatment, or putting too much of the responsibility on patients. And the reason I'm pushing here is that I think you can get into a moral argument that, of course, patients should be managing their own care, and now that they have the tools to do that, this is just like managing your own finances and managing your own travel, and we're used to doing that with technology, and the incumbents always moan about this and say, people are going to make mistakes, and eventually we realize, no, people can manage their finances and their travel with good IT tools. Healthcare feels different to me, and I think at least until it's not different and we figured out the IT, we've got to be very careful here. The story I love is the story of Franz Engelfinger, the editor of the New England Journal of Medicine, one of the most prominent people in medicine from the mid-60s to the mid-70s. Engelfinger was probably the world's expert on diseases of the esophagus and stomach. And as irony would have it, he developed cancer of the distal esophagus, that's sort of the area that he was the world's expert. And as Engelfinger went from doctor to doctor in Boston to try to get help for his problem, each one of these doctors said, well, Franz, what would you do? Deferring to this great expert to help make his own decision. And you think this is not just a regular layperson, it's the world's expert on this disease. Of course they're going to defer to him to make his own decision. And in this article, Engelfinger wrote, I have subscribed for some time to the principle that the physician must be authoritarian and paternalistic to some degree, and my experience as a patient has substantiated that belief. I receive from physician friends throughout the country a barrage of well-intentioned and contradictory advice. As a result, not only I, but my wife, my son, my daughter-in-law, both doctors, became increasingly confused and emotionally distraught. Finally, when the pangs of indecision had become nearly intolerable, one wise physician friend said, what you really need is a doctor. In other words, someone to really take this responsibility off your hands. When that excellent advice was followed, my family and I sensed immediate and immense relief. Now, I don't want to take that argument too far. I think that paternalism in general is bad. I think patient empowerment and giving patients more information to help them make decisions is good as a general rule, but you could see in a world where there's more and more information available to patients through the web and co-pays and deductibles are going up, there will be this pressure for patients to do it all themselves. And I think the biggest danger is, I think about safety implications of this particular part of the sort of nexus between transparency and patient-centered care and information technology. I have to say that this is the part that scares me the most. Let me hand the baton back to John, and I look forward to hearing what Beth has to say and to the Q&A, and then moving on to the second section. Thanks very much.
Great. Thank you very much, Bob. Thanks for an excellent presentation, and I'm looking forward to the next piece. The first part of that, before we go to question and answer, is to introduce Beth Daly-Ullum, who will serve as a reactor. Beth is a passionate advocate for patient safety and quality, and she really does her work with hospital leadership teams and boards of directors and industry leaders. And the work is to develop programs that improve the quality of patient care and make patient patient-centric approaches and outcomes transparent and accessible. So I'd like to invite Beth now to provide your thoughts on the presentation, provide your thoughts on the subject from your vantage point, and feel free to add any introduction that I've missed that you'd like to. Go ahead.
Thank you, Jonathan, and thank you, Bob. So I was really mesmerized by Bob's talk, especially about the history and evolution of healthcare IT and how we're really at the nascence of what's to come, and really the changing this relationship of how IT improves our care and how IT helps the patient in that process. And so it's really exciting to me what is to come, but as a patient advocate, I just want it to be here faster, and I want all of you to do your jobs faster and better so that IT is working better than it is currently for patients. One thing I'd like to caveat is it's really hard to speak as a reactor, as a patient advocate, because the needs of patients are so different, and there is no one ubiquitous patient. So how do you build an IT system that serves all these patients when their needs and the way they interact with the systems are very different? You have the very active self-diagnosers on one end, and then you have people that are comfortable with sort of the old patriarchal trust me way on the other end, and you have language issues and navigation issues and issues around mobile apps versus using them on a computer. So the whole way you talk about engaging patients when there's no one common denominator. But, you know, it's not something that's insolvable. Other industries have adapted to serving patients or serving customers in different ways that they use IT very successfully. So I think we need to really look to other industries and how their IT has served a spectrum of different users and different interfaces. One of the things that is sort of my fundamental question with health IT is in regards to patients is, what is the information needed by a patient during each phase of care, and what role does health IT play to enable and support that? And I think Bob really highlighted well some of the dangers and some of the opportunities. But our current state really doesn't give patients enough information to make good choices. So we talk about this notion that Bob mentioned of patient engagement. And I really believe that it is hard to be an engaged patient if you don't provide access to information, both outcomes, safety outcomes, clinical outcomes, and ongoing care. So an uninformed consumer, to me, cannot really truly be engaged. And this is something that I personally have struggled with, having a medically complex child. You know, I was kind of almost giggling here as Bob was talking about these different scenarios. I've been the misinformed consumer when my son was first diagnosed with tetralogy of Fallot, and, you know, at 3 in the morning I was researching to try to understand tetralogy, and I found on a website that children only live to usually about the age of 10. And I was crying, and my husband came in at 3 in the morning, we're crying. Finally we looked, and it said in India. So I was sort of embarrassed because I'm a fairly well-educated person here, and I had allowed myself to spiral into the abyss of the internet and into the abyss of this misinformation. So one of the big challenges is just on the front end when patients are trying to collect information that you, the leaders of the healthcare IT world, have to help them better sort good sources from bad sources. And I was a victim of that as well. So then I got better at trying to sort that information. But what I found when I was really trying to understand variations in the clinical outcomes for tetralogy was that the surgeons, for the most part at the time, weren't publishing them, or it was very varied who would publish them. So to really gather that information was very burdensome. And when I finally did gather it, there was enormous variation in the clinical outcomes for my son's diagnosis of tetralogy that really ended up driving where we sought his surgical repair. So, you know, really looking at acute clinical condition or ongoing conditions that are chronic conditions that you'll search for locally and getting those outcomes, and looking at acute conditions that you would get a surgery and want to see the variations nationally. I think we need to help sort that information better. And I know there's some really good collaboratives that are trying to make that information available and accessible, and I think we just need to accelerate and really make that information both available and accessible to be able to sort for patients based on what their priorities are. And it was interesting for me, my son who has tetralogy is now 7, the difference. I had a friend whose child was diagnosed with tetralogy 2 years ago, and her availability to sort information was much better. So we're making progress, but we're still not where we need to be. The other thing that Bob really talked about in terms of looking through the patient eyes was this notion of open notes. And I really, in my call to action, I would like all of you to consider pushing your institutions towards open notes. And I know it feels scary, and there's some complicating factors in particular regard to behavioral health around them, but eliminating the whisper factor and creating a sense of trust with the patients, open notes is critical to that process. I was just hospitalized with my son for respiratory issues for 3 weeks, and the whisper factor, when you feel like they're rounding outside your room, you can't see your information, it really breaks down the trust, and really, you're not able to help contribute to your care. And I think there are a number of IT solutions that are out there trying to create ways for patients to push information into their EMR. And I think one of the real great things after everyone starts to adopt open notes would be for everyone to start to consider not just giving patients access, but giving patients a participatory role in creating their EMR, which I know is really way out there. And lastly, the longer term thing I really hope that Bob mentioned, and this will lead into Bob's next section and Marshall's work, is really making those outcome metrics and safety metrics comparative. It's really hard when you just publish your own information for your hospital and it's not comparative. And I think patients are looking for comparative information, and institutions really will improve when that comparative information is made available. And I'm involved with the Solutions for Patient Safety Pediatric Network, and we've seen the whole ocean rise as all of these 81 pediatric hospitals have had a single dashboard for safety and created a learning network so that everybody can get better on their key safety metrics. So I think patients are expecting a better interface from hospital to patient and from doctor to patient, but they're also expecting healthcare IT to work better internally so that that data mining, those algorithms, those comparative metrics, and that learning is happening within the institution to improve care, improve diagnostics, and improve the safety of the institution where they're going. So at that, I'll turn it back to you, Jonathan, and thank you, Bob, for your work in calling so much awareness to the important role of healthcare IT in creating better patient care.
Great. Thank you very much, Beth, for your thoughts and stories and your insight on this. What I'd like to do is now turn to questions that are coming from the audience, and so please use the questions feature to type questions, and we will take a look at those and pass those forward. We have about 15 minutes now to talk about the first presentation, and then we'll go into the second one. And I wanted to start it off with a question that came to me as I listened to the excellent presentation, and the idea that that transparency for the patient, for the individual patient, in many ways represents culture change. And the question is, are patients doing enough to drive transparency? And what specifically can patients do, should patients do, in order to nudge the culture and to improve the transparency, maybe possibly for themselves, but possibly for others. Would love to get your thoughts on that, Bob and Beth, and Marshall, if you have some thoughts that you'd like to add as well, that would be great.
Well,
starting with Bob?
I could start and say I think that I cut my teeth in the world of healthcare working on AIDS and HIV in the 80s when I came to San Francisco, and it was this overwhelming issue. And one of the things it showed me was the power of patient advocacy for basically a very large group of patients and their representatives said, we are not going to accept this idea that you are all the experts and you have all the knowledge, and we're going to sit here on the outside and wait for stuff to come to us. And I think you can argue that that movement has saved tens of thousands, if not hundreds of thousands of lives by accelerating the science and drug delivery and all that. And I don't think we've seen that level of advocacy here in general transparency, I think in part because it seemed impossible. It's one of these things where, just getting a comprehensible bill out of a hospitalization seems hard enough. The idea that I'd want sort of full access to all of my data it seems almost that much harder. And I think the legal system has provided another obstacle that's created too often an adversarial relationship between the delivery organizations and patients and led to hiding the ball more than is appropriate. I think what you need is these sort of early exemplars of organizations that have embraced transparency, doing it, and seeing that the sky doesn't fall, and in fact it makes many things better. And what I'm hoping is that we have people like Beth and others who are saying, look, it can be done, and it's not like we're against you, doctors, hospitals. We're on the same team here. We're trying to do the same thing. It can be done in a way that's sensitive and collaborative, and we want to move that forward. I don't think the level of advocacy on this issue has been strong enough to overcome the resistance. But as I say, I think IT changes that dynamic, so the amount of pressure that's necessary to, for example, open up the gates for open notes becomes much, much less than it would have been if we were still on paper. So I'm much more hopeful about it now than I would have been 5 years ago.
I would just add to that, to me, there's so many people advocating for other parties in healthcare. You have organizations that advocate for hospitals, for doctors, for the specialty societies. And who's really sitting at the table nationally saying, look at our tax dollars going to this and this and this, and where do we carve out something that says there are some patient rights that have been overlooked for a long time, and that needs to be remedied. And that's something that I think we're right at the start of seeing here, because, it's a little bit like, it reminds me of the book that my kids love, The Lorax, and the Lorax is saying, I speak for the trees, and nobody's hearing them. And I think there's an element of the transparency that needs to be part of the national discussion, and really allowing the patient's right to a transparent system to be put forward as more important than it has been. And certainly also beyond the national level, on an individual level, there are very distinct things that each patient can and should and has to be taught to do, just like financial systems have had a really big outreach program since Sarbanes-Oxley to retrain their system how to better disclose to customers. I think we need to have a better system to do informed consent, to share information, to make information sortable for patients, and teach patients how to ask those questions and be more engaged. We just don't have that sort of training, and we need to retrain them how to be an engaged patient.
And I think the systems have to be better too. I think part of there's kind of a Maslow's triad here, or scale, where the systems are still too clunky for expert users to be comfortable using them, and until they are, it seems hard to believe that they'll be easy enough and user friendly enough for the non-expert to use them. Although you could argue that the other way. You could argue that part of the reason that many of the systems are clunky and the user interfaces aren't very good is that they were designed as expert systems without a whole lot of sensibility around, the user experience, and had they been designed from the consumer's point of view on in then to the enterprise, they would look more like Google or Apple or the kind of consumer-friendly sites that we're all used to. And I think now that they are being designed, or many of them are being designed around the consumer world, now that Silicon Valley is kind of woken up to healthcare IT, I think you are going to see massive improvements in the user interface. And ultimately, the expert systems will get better because they'll migrate from the consumer systems that know how to do this.
So we have a question coming in about the idea of, I guess, erasing information, or patients who see information that they sometimes feel is inaccurate, sometimes they just don't like. One example might be, at least from years ago, when patients would come in and say, please don't record my HIV status in the chart, that's too sensitive. Wondered if you have, either of you, Beth or Bob, have some thoughts about that kind of challenge.
When you start, Beth, if you have something.
Sorry, what was that, Bob?
Go ahead, and if you want to start.
Oh, this is one where, like Bob said earlier, will the improvement or the risk outweigh the improvement opportunities? And for every case that you end up with a situation where someone wants to hide something, you're going to probably, my guess is, have 5 cases where things were overlooked or not recorded rightly, and patients might correct something in the system. And I've seen that left and right in our own family's care. Oh, you put down the wrong med, you put down the wrong dose. And I only am able to do that because I'm looking over their shoulder while they're typing onto the portable little computer. So, which they don't really like anyway. So, how do you weigh the cost benefit of the risk of trying to hide information versus the opportunities to have better information and input into the system?
Yeah, incredibly tricky one. That the Seinfeld episode really captured it. Are we going to be running around spending all of our time fake erasing? And the experience so far with the open note sites has not been all that problematic. It happens. There has to be a mechanism created to correct something that is wrong. And as Beth says, I think the greater good here is for patients to be another set of eyes and say, that's just not right. But then, then there is these more fraud issues where, the doctor said, I'm obese and I don't like that, or I don't like that characterization, or around mental health issues, or around substance issues, or around just disagreements, and these will happen, and around the characterization of a given condition. I do think a risk of open notes and things like it is that doctors will become much more careful in what they write. You might say that is a benefit, but there will be times where the chart and the note as a vehicle to inform my colleagues what I'm thinking or what I'm worried about, and some of it might have to do with the behavior or personality of a patient. There's no question that all is going to get censored out, and it's going to leave the note a little bit more blandified than it is today. I see that as a downside. This issue of the patient and the doctor being in dispute about something, I think there's got to be a mechanism that somebody adds a comment to a note that it remains in dispute, and these two parties have different views of it. I don't think either one necessarily should win, because they may very well have different views, but somehow the record will need to accommodate that. And
Jonathan, I'll give a interesting example. When my son was working on some feeding therapy, with an inpatient feeding therapy program, he's tube-fed. In the notes, they had written that the patient is late for therapy. And I was so upset when I saw that in the notes. And I said, you guys, I'm late by 10, 15 minutes because the food doesn't arrive on time from the cafeteria, the people who prepare the nutritional food for him that I have to bring to the therapy. So I can't go to therapy till the food gets here. And so you had written that we're late and that you were concerned about our commitment to the program. I'm only late because the food's not here. So it was such a basic thing to correct, but they had written something that I felt, really was reflective of an operational problem and not my commitment. And so, I think the greater good will outweigh those small risks as we transition in that cultural shift.
So Beth, thank you for your story. I'd like to follow up on that because I think what you're saying is that perhaps there are things that you would like to say to the care team to help them do their work better and to help them be more inclusive. And when you and I were talking separately, I think you said that it wasn't easy to say those things to the care team, that, it sometimes feels like you're, well, it goes back to the Elaine in the Seinfeld. It feels like you're somehow stepping out of your role of being a good patient maybe, or a good family member, or being disruptive, or, something like that. So what I'm wondering is, to both Beth and Bob, what are the kinds of things that you would like to say to the care team, and that you'd like the audience of hundreds of people listening right now who are patients themselves from time to time? What can people say?
Well, I would just add, open notes is just a start to me, Jonathan, because I think there should be a bedside interface where patients can push information into their EMR, and it can be sorted and categorized in the system to go to the different people that it's relevant to. So I could maybe push some information into the system that might get flagged by the environmental services staff. I could push some information that I might want to add to the care team, like, hey, my son's food is not coming on time, so I'm late for therapy because the food isn't coming up from the kitchen. So I think finding ways for patients to appropriately push information and categorize their concerns, and also create a tranching system of ones that are immediate red flags that are patient harm issues versus ones that might be of lesser nature, more of a satisfaction, my pillow's not soft sort of issue. So I think that what's coming down the train, in my view, and I hope it comes faster than the last 10 years have come, but like Bob said, now that really Silicon Valley is awakened to the opportunity in healthcare IT, I hope to not just see open notes, but I hope to see that there is a role for patients pushing information in and not just pulling information out.
I think that's absolutely correct, and I think this is an example. In the book I wrote about this concept called the productivity paradox, where we think we're special in healthcare, but at every industry that has basically transformed from analog to digital, there have been predictions that it's going to make things great and cheap and efficient and wonderful, and 3, 5, 7 years go by and not much happens. And people start hand-wringing and saying, what happened? And then about year 8 to 10 or 12, things start getting better. And it's because the technology gets a little bit better, sure, but the real thing that happens is people begin reimagining the work. And that's because young people come in and they say, why do we do it this way? And they say, oh, because we used to have these things called paper notes, and doctors wrote on them, and the patients didn't see them, and the nurses wrote their notes in a separate section. And then when we electronified it, we just made that all faster. But it's still stupid. It's still, in a world with, with Twitter and Wikipedia and Facebook, who would have invented the structural characteristics of the modern note? That would be crazy. And all we did was make it electronic. But, what will happen over time is that people will listen to folks like Beth, and companies will come in and say, here's a new way of imagining what the note looks like. It's a collaborative thing. It looks more like Wikipedia. It's got a home page, and it's got streams of information and a wall that's more like Facebook, and it gets information from a patient or family member to the dietary folks seamlessly, and it gets, it gets sorted in terms of levels of importance. That's not that hard. It just takes us all taking a good step backwards and saying, what are we trying to accomplish here, rather than how did we digitize this ridiculous structure that we've come up with called a note.
Great. Well, I hope that before we finish the session, by the end of the session, we've also had a chance to talk a little bit about almost for an individual, what can they say? So So Bob, when you're rounding on patients in the hospital who are doubtless, some of them experiencing the kind of whispering going on around them and wishing it was different, is there anything the patient can say? Is there something the family can say? I'm just thinking about, kind of almost, personalizing that answer, that thought, because I've been in a similar experience, even as as a medical professional. It's not easy.
Sure, no, it's unbelievably hard, and I like to think, but maybe all of us like to think that I encourage that, and then I'm pretty accessible, and I do things like sit down and try to make sure that it doesn't feel like I'm running for the exit, but I'm there to listen, and I'll ask, what questions do you have for me? But I'm sure there are times where I give the aura that I'm rushed, because I might be, or that if for the patient this feels still really, really hard, because what if it's a bad question, or what if the doctor feels like I'm challenging his or her authority? And I think one of the benefits of now at least the potential to reimagine the work is changing the overall culture, so that you change that power dynamic, so that patients now are comfortable asking that tough question. That might be harder than creating a new portal on an EHR where the patient can type in a question and the doctor or the nurse or anybody else sees it, but they're not in the same room and can react to it in different ways. It has a different sort of emotional valence. And that's why I think we kind of have to start from first principles. What are we trying to accomplish? What are our values? And how can IT make that happen or enable it in new ways that we just couldn't have done before in an analog environment? That's probably easier than changing the power relationship between patients and doctors, so that Beth will feel more comfortable the next time. And think about, Beth's an incredibly knowledgeable, accomplished person, and still she is worried about it. I'm worried about it when it's my mother in the hospital, and it's a hard thing to do, and I'm less confident changing the culture than coming up with new tools that allow patients and families to do this more seamlessly.
Well, thank you. Let's go to the next presentation, in which we'll be talking about the implications of transparency on health IT at the level of providers and healthcare delivery organizations. And so, Bob, back to you.
Great. Thanks, John. I'll go quickly here, in part because I think I tried to introduce much of the foundational material in the beginning, so I'll just kind of refocus all of our lenses at a higher altitude here, and also in part because I'm really looking forward to hearing Marshall talk about his thinking about this and his recent experience in the work he's been doing with ProPublica. Let me start with Quality 101. Apologize to those of you who know this, but it's, I think, foundational. This is Avitas Donabedian, really one of the fathers of health services research, who developed what we now call Donabedian's triad, the ways that we think about measuring quality. And what Donabedian says is you can measure process, structure, or outcomes. Process is what was done. Did the patient who needed them get beta blockers? Did the clinicians wash their hands? Did the surgeon use a checklist? Did they do a thing that at least we believe or evidence supports that if you do that thing reliably, care is better? Structure, how is care organized? Does the hospital have computerized order entry? Does it have a stroke unit? Does it have high volumes? Are the doctors board certified? Is it a magnet hospital? Those are structural measures. And again, we care about them mostly because of some, at least theory or empirical data that associates having that thing with the outcomes that we care about. In the case of both process and structure, really they are surrogate markers for what you really care about, which is how did the patients do. And sort of typical outcome measures are mortality rates, infection rate, readmission rates, what actually happened to the patient. If you think about it, that's what we care about. And yet that's in some ways the most difficult thing to measure. And here's another area where IT changes the equation and changes that tug of war, and I think shifts us quite smartly toward outcome measurement with some real benefits and also some new challenges. So why did we need to mostly use process, structural, or reputational measures in measuring quality over the last 20 or 30 years? If you think about U.S. News and World Report, I forget when it was, but up until 7 or 8 years ago, it was largely a reputational measure. They asked every rheumatologist in the country if you could, go to one place to get your complex rheumatology care, where would you go to? And that's the U.S. News top 10 hospital list came from that. Over the years, they have dialed down the percentage of their measure that's from reputation. I think it's down to about a third now. And now they're using empirical data for the rest. But in the past, when we were talking about paper charts, it was very difficult to abstract clinical data. It meant someone had to go and try to read my handwriting. That's not an easy thing. Make sense of it. And so it was just easier to, A, look at what your reputation was. I could do that with a survey. Or look at your structure. Do you have a stroke unit? I can kind of figure that out without having to read charts. Or even process measures. I could look at your prescriptions and see if a patient with a heart attack got a beta blocker. So extremely difficult to abstract, made it easier in some ways to focus on process and structural and reputational measures. There were computerized data over the last 20 years, but essentially they were all administrative billing data because we did have to send a bill to Aetna or to United or to Medicare. And so being opportunists that we are, we said, all right, there's computer data. We'll use that to measure quality. But as some have written, it's data exhaust. It was not created for that purpose. It was created for the purpose of sending a bill. And so using it to try to measure quality is quite hazardous and often gives you wrong answers. And part of the problem here, if your bias, as mine is we'd love to use outcome measures. We really don't care whether you got a beta blocker or whether hospitals computers. We care that you're alive, and if you had a hip replacement, that you're happy and playing golf 6 months later or whatever it is. But in order to do that, you really have to be able to adjust for how sick the people were, or you'll come out with wrong or unfair results. And the science of case mix adjustment wasn't very good. And the substrate for case mix adjustment, which is sort of deep clinical knowledge of how sick the people were, was not very accessible because it either required massively expensive and complex chart abstraction, or again, using that billing data, which was not created for that purpose. So here's another one where the tug of war changes. Health IT facilitates measurement in many ways. We are now collecting in digital form clinical data, not just for the purpose of billing, but that theoretically will allow better case mix adjustment. You know, we can look at an electronic record for a patient and say, wow, that patient has diabetes and heart failure, and this is their ejection fraction, and this is their hemoglobin A1C, and I can use that in a measurement scheme to basically know how sick they are and therefore adjust for that as I'm trying to make sense of their outcomes. EHRs also allow follow-up, particularly once we move toward interoperability, or if you're in a closed system like the VA or Kaiser Permanente, but hopefully eventually all of us will be in a healthcare ecosystem where a patient who gets care at UCSF but then goes and gets their follow-up care at a different place, the system still knows who they are and can follow them up for their outcome, something we couldn't do in a paper world and can only do to a limited degree in a non-interoperable world. Process measurement, yes, we now can more easily measure, did you give this or that, or did you do discharge counseling? That's not an unalloyed good, because we all know that the way that's being dealt with now is the creation of templates and checkboxes, and there's a lot of playing for the test, and I think a fair amount of fiction as well as we look at people checking the box saying they did discharge counseling. You know, did they really do it? Some of the times we don't know the answer to that. Eventually, not quite yet, but around the corner, natural language processing may allow data elements to be captured despite non-structured data. One of the great tensions here is the computers right now really move us away from the narrative description of the patient's story, something that's really important, connects us to people as people, and moves us toward pushing us all to chart by checking a whole bunch of boxes, because it's easier for the computers to measure that and use that in a quality measurement scheme. The hope is over time that we won't have to do that. We'll be able to put together a narrative note, and the computer will figure out whether you did discharge counseling or smoking cessation counseling, because it's embedded in your pros, and the computer will be able to read your pros, moving us away from the need for checkboxes. That's a hopeful trend, and I think we'll get there over the next several years. And on the kind of the output side, if you think about, okay, there's a lot of data sloshing around through the electronic health records, and there's new ways of analyzing it. Maybe we can start doing case mix adjustment. But in the old days, the only way of then getting the data out there in front of people or insurance companies or the government or other proxies was either a published article in the literature or a published article in a newspaper. Well, now there are, you know, a bazillion different vehicles by which one could get information out there to the public, and that's partially what's so exciting about what Marshall and his colleagues have done. But it's not only the kinds of information that we like to create ourselves, like a patient portal, but it's Yelp and Twitter and other all sorts of democratization of the ways people get information. Now, are people getting information that way? You know, you betcha. Here is the Pew study from 2012. I'm sure these numbers have gone up, but you see larger and larger percentages of patients who are consulting reviews and rankings for drugs, doctors, or hospitals. And you see that younger people are doing this more than older people, even though the older people are probably the ones who are using healthcare more. I think this is just a generational curve. It seems very unlikely to me that those 45-year-olds, when they turn 65, are going to stop using the internet to get information. So this is only going to grow as our population ages. What's the good here? Well, tons of good. Transparency leads to both consumer choice and clinician system improvement. I'll get to that in a second. The measures are getting better over time, particularly as we're beginning to learn to use electronic health data in new ways. We're beginning, as I mentioned before, to present this information in a more user-friendly way, tailored to patient preferences and needs. And as I mentioned before, I think the entrance of Silicon Valley into this world is crucial, because they know how to do this in other domains, and people in healthcare typically do not. It's the right thing to do, and I think the most important thing is that transparency in terms of report cards and public reporting works far better than expected. And you'd asked me 10 years ago, how important is the public reporting of hospital data on whatever quality measure you care about, or patient experience measure? I would have said, well, I think it's going to be pretty important if it leads to consumerism, if it leads to patients going online and looking to see that hospital A is better than B and I'm going to A versus B. There's actually relatively little of that that's happening so far. I still think people are more apt to look up the Consumer Reports rating on a refrigerator than they are to look it up on a doctor or a hospital. But even in the absence of a whole lot of change in consumer market behavior, we do see major changes in healthcare organizations doing backflips to try to improve based on public reporting. And I think the mechanism is more shame and pride, and a lot of people are used to getting A's on tests and don't like getting C's, than it is consumer behavior, although I think that's going to change over time. Here's one study that just shows how both important transparency has been and how disappointing payment change has been. This is Medicare's early experiment on pay for performance. And what it shows is in 2003 to 2008, so still pretty early in this field, the hospitals that were part of the Premier system that were under pay performance, that got paid more if they did better, you see that they improved on a bunch of quality measures that were publicly reported. But more impressively, the red curve is the rest of us, the hospitals in the United States that just had public reporting of their data on performance, for example, heart failure, pneumonia, and MI. And you see massive improvement in those hospitals, improvement that essentially matches the improvement that you got by public reporting plus pay for performance. It's not that pay performance can't work or never works, but I think the experience of the last 10 years is that transparency works better than we would have expected, pay performance works less well than we would have expected, and transparency is much, much easier and less politically charged, because you don't have to make all sorts of administrative decisions about do we pay the best players or the best improvers. What's the bad? Lots of bad. We're applying now fancy analytics to crummy data, a lot of data that's copy and pasted, or a lot of playing for the test. I don't care how good you are at your analytics. If you're starting with crummy data, you're going to get crummy measurements, and I think we're seeing that. Case mix adjustment remains a relatively young and immature science. We have a lot of playing for the test. We have a lot of people checking boxes and focusing less on the patient than on the box checking, and also I believe there is some fiction there in what they're checking. And as Marshall will tell you in a second, providers get very angry very quickly when they believe they're being mischaracterized as being bad when in fact they're good. And some of them probably are good. And so until we get the case mix adjustment perfect, and the case mix adjustment is not just that the patient has diabetes and heart failure, the case mix adjustment is the patient is poor and doesn't have access to a pharmacy or fresh vegetables or can't get in to see a primary care doctor. Until we can adjust for those things better, there will be some unfairness in the measures, and some of the hue and cry will be appropriate. So here's Churchill's famous quote, "Democracy is the worst form of government except for all the others." And I'd say that IT democratizes healthcare. And will it follow Churchill's quip? I think the answer is yes. I think that even though people are objecting to public reporting of data, and it's not fair, and you didn't get it right, and you didn't get case mix adjustment right, I think the only way we're going to get better is to begin doing this, to hear the pushback and the feedback, and to iterate and improve. And I think ultimately the democratization of healthcare is for the better and will lead us to better, safer, more patient-centric care. So I'm actually quite excited about it. With that, let me turn you back to John and then to Marshall.
Great. Well, thanks again, Bob. And I'd like to briefly introduce now our reactor, Marshall Allen, a reporter for ProPublica. He and his colleague Olga Pierce recently published the Surgeon Scorecard from ProPublica, which includes risk-adjusted complication rates for 17,000 surgeons nationwide. He's also written Do No Harm, Hospital Care in Las Vegas, collaboratively with Alex Richards for the Las Vegas Sun. He's been honored with several journalism awards, and his healthcare coverage was recognized as best in the country in 2009 by the Association of Healthcare Journalists. Before he was in journalism, he spent 5 years in full-time ministry, including 3 years in Nairobi, Kenya, has a master's degree in theology, and we're really very pleased to have Marshall here today to begin the conversation around the last presentation. So on to you, Marshall.
Thank you, and thank you for the invitation to speak here. I really appreciate it, and I'm excited to tell you about what we do and to hear more about what you all have been doing. So I think I'd start by talking about ProPublica for those who aren't familiar with us. ProPublica is a nonprofit investigative news organization, and our tagline is journalism in the public interest. And so when we cover healthcare, our journalism is really focused on how things affect patients, who are the people who are most affected by healthcare, and obviously the ones who in the end are paying for the healthcare as well. And ProPublica has become known. ProPublica has been in existence for about 8 years, and we've become quite known through the work of some of my colleagues for taking data and making it presenting it in a meaningful way, particularly related to healthcare. And so we have our project called Dollars for Docs, which looks at pharmaceutical payments to doctors. Prescriber checkup, which some of my colleagues did, is looking at the way doctors prescribe based on a release of Medicare data. And then Treatment Tracker is another one of our searchable databases where, again, this is looking at the release of Medicare Part B data, looking at how doctors treat and what type of procedures they do on Medicare patients. So Surgeon Scorecard is kind of standing on the shoulders of these other ProPublica projects. It's in alignment with this mission that we have. And the real goal with Surgeon Scorecard is to leverage the power of transparency to spur improvement. As I'm sure the audience here knows, patient harm is one of the leading causes of death in America by many, many estimates. And when patients go for a common elective surgery, like the type that are included in the scorecard, they really haven't had any information to make a meaningful, informed choice about where they go for an elective surgery. There hasn't been that data on outcomes like Dr. Wachter was talking about available to patients. And so one of our goals was to inform patients so they could make meaningful decisions and informed decisions. But our second audience here has always been the medical community. And we know that the medical community wants to provide the best possible care, but sadly, the medical community doesn't always have the most meaningful information to see how they perform and also how their performance compares to each other, whether it's in the same hospital or in other hospitals. And so we believe so much in the power of transparency. I mean, we know that there are studies that have shown that consumers don't use a lot of this information, although we think they do based on our experience. But we do know that providers will, and so that's why the medical community is as much a target audience for our work as the patients are. So what Surgeon Scorecard contains is the risk-adjusted complication rates for almost 17,000 surgeons on 8 common low-risk elective procedures. So with the procedures we selected were knee replacements, hip replacements, 3 types of spinal fusions, gallbladder removals, prostate removals, and prostate resections. And we chose that kind of menu of procedures based on the advice of dozens of doctors, including surgeons who do each of these procedures. We talked also to the top researchers around the country who work with this type of data, and we really listened and took their advice about what the procedures were that we could reliably include in this analysis so that it would be accurate and fair to everyone involved. And one of the really important things here is how we define complications. You know, again, we're using administrative billing data. So this is data that Medicare puts out. It's really the only nationally available data set of its kind for this type of a purpose. Unfortunately, there's no national data set that gives you information on all patients. But it's administrative data. It's used for billing. You know, this is hospitals are required by law to accurately report this information to Medicare. And so while there are problems with lots of data that gets submitted, this data has been collected for a long time. It's a pretty clean data set, and it's actually, and the way we used it, we think is very reliable. We negotiated with Medicare to provide us with the identity of the surgeons in our data set. There's a field in the data. Basically, each row in the data is a record of a patient inpatient admission, and it's de-identified, of course. There's no information in there that will identify the patient. But in each field, you have the operating surgeon's ID. And so that used to be an encrypted ID, but a couple years ago, Medicare started releasing a lot more information about payments to doctors. And so we asked Medicare if they would please provide us with the unencrypted physician IDs in our data, and they were kind enough to grant that request to us. And so Medicare provided us with those surgeon identifying national practitioner identifier numbers, and now that data is released to other researchers as well, with the surgeon IDs included. And so, you know, if people are wondering, will these type of analyses continue, I really think that they will, because we kind of did this first, but there will be others who will follow in our footsteps, I'm sure. One of the important limitations of our data is, again, it's administrative data, not clinical data, and so we wanted to be very careful about how we defined the complications we're measuring. So again, based on the input from dozens of doctors, including surgeons who did each of these procedures, we only counted any time a patient died in the hospital upon an admission for one of these low-risk cases, or any time they were readmitted within 30 days for a complication that was considered related to the procedure. And the way we determined that is we had about 24 doctors volunteer to review every reason patients got readmitted after one of these index procedures. And then they told us whether or not that readmission would be something that we should consider a complication related to the surgery. So we end up counting things like mostly surgical site infections, blood clots, problems with an orthopedic device, you know, hemorrhaging. We don't count things like Alzheimer's disease or even congestive heart failure or heart attacks. Our panel of doctors told us that a lot of those things with our data, you just can't tell whether or not they're related to the surgery or not. And what we found, as you would expect, these are low-risk surgeries, and so our average complication rates are fairly low. We did risk adjust all of the findings to make sure that we're fairly comparing surgeons who are operating on similar patients. And the average complication rates are between 2 and 4%. But what's interesting is you do see a lot of variation. There are hundreds of surgeons, each who performed at least 100 surgeries, who had 0 complications in the 5 years combined that we did this analysis. And there were hundreds of others who had complication rates that were very high compared to others. They had 2 or 3 times the average. There were some surgeons who did a fair number of cases who had complication rates of this type higher than 10%, which doesn't sound that high unless you realize that sometimes in the exact same hospital, there's another surgeon doing the same procedure who has a complication rate of about 1% or close to 0. And so another limitation of the data, which we explained, is that the data doesn't tell us why a complication occurred. The data can only tell us that the complication did occur. And so we name surgeons not because we know that they're to blame for all the complications, but because we know that surgeons are responsible for the entire episode of care, especially on these elective cases. The American College of Surgeons has determined that, and any doctor or surgeon we've talked to has agreed that the surgeons are responsible for complications, even if they aren't necessarily to blame. I think we're kind of, with this project, capitalizing on some of the things that Dr. Wachter talked about, these two transformational movements in the healthcare system. He mentioned there's a lot of pressure right now to deliver high-value care. And then he mentioned the digitization of the U.S. healthcare system. What we're trying to do is really leverage that pressure to deliver high-value care combined with the power of transparency, where now patients have actually the ability to choose where they go for care. And that's also one reason we picked elective surgeries, is because in these cases, patients do have the power to choose. And so we're really trying to leverage that to spur the improvement within the medical community. And so we really think, and we're seeing already, that the medical community will take this information and look into it and act on it and see what they can do to improve. I want to add a third trend, and Dr. Wachter mentioned this, another transformational movement in the healthcare system. And I would say that's also the digitization of the patient population. Patients are more and more tech savvy. They're being told to embrace the responsibility for their health care. They're taking on more and more of the financial risk for the care they receive. And so patients are much more attentive and attuned to where they're going for their care. And Dr. Wachter said that 59% of patients have looked online for health information. And we've seen in the first month of our searchable database being released, we have seen about 1.7 million page views on the database, which is quite high just based on the other things that we do. With the surgeon scorecard, people can look up individual doctors by name. They can look up hospitals, and they can see all the surgeons within their hospital. They can look it up by a city or by a state, or they can even type their address in and see how the doctors around them perform. As Dr. Wachter mentioned, there has been some backlash, although I would say the backlash has actually been quite minor compared to how, what we just did in terms of publishing almost 17,000 surgeons' complication rates. We really haven't had a lot of backlash. We've had some very vocal critics. What the critics tend to do is express the limitations of our analysis, which we've already expressed. Only they present them as fatal flaws that show that we've been irresponsible, or that we should not be doing what we're doing. And actually, I've been encouraged to see that the critiques so far have not, in my view, had a lot of merit. Like, they'll criticize us for only using Medicare data, when everybody knows that, the government uses Medicare data, other researchers use Medicare data. Unfortunately, it's the only available. They'll criticize the fact that we're not measuring all of the complications that occur to patients. There's a lot of complications that we just can't see in the data. And again, we are clearly defining the complications we can measure, but we are not pretending as if we can measure all complications, and nobody would be able to do that. One prominent critic said that there's a propensity for some doctors to readmit patients. But there are no observation stays in our data. The average length of stay of our complications is more than 5 days, and the cost to Medicare for the readmissions alone was $654 million. So these are not all just minor complications. And the most encouraging thing has been all the support. We've had insurance payers and quality improvement organizations who are interested in purchasing our data to use it for their own internal quality improvement work. And I'll finish with this feedback, like this email we got from Dr. John Cooper, who's in charge of quality for the Palo Alto Medical Foundation. And he wrote in and said, and you can see this on our website, his quote, because I included the whole thing. I won't read it all now. But basically he said, a lot of he does quality improvement for a physician group that's over 1,000 specialists. And he has a hard time getting basic data from some of the hospitals where these physicians work, because they're not all owned by his same company, and it makes it difficult to get this information. So he was writing in to say he's going to be sharing the surgeon scorecard information with others, and he wants to help us even look at how to expand it. I have some other things I can talk about, but I think we better go to questions here.
Great. Thank you very much, Marshall, and I apologize that we're running short on time. But thank you for pointing out the complexities of the data, and at the same time the importance of, like with the surgeon scorecard work, really going out and getting that information and making it as transparent as possible so there can be learning. What I'd like to do is actually just go to the next slide, and let's see. Yes, what I wanted to do is make sure that folks on this webinar are aware that the last webinar in the series is scheduled for September 10th, 1 o'clock Eastern Time, and it's going to focus on the Health IT Safety Center roadmap. So it'll focus on the work of the overall project that these webinars fit into, that proposes a National Health IT Safety Center. The website and the email address that are shown on this slide are the same as I showed you before. And on the last slide, if we can go to that, I just wanted to acknowledge that this webinar series has been part of this broader project, a collaborative work to really develop a roadmap for a Health IT Safety Center. And so that work under the leadership of the ONC is going to continue in terms of the planning activities, and we've really been pleased to offer this webinar series as an example of the kinds of activities that we feel are important for promoting Health IT safety. So with that, I will thank all three of our wonderful presenters and reactors, and invite you all to download and look at the slides and the audio from this webinar. We'll post those within a few days, and invite you to join us on September 10th. So thanks very much. Have a great rest of your day. Bye-bye.